Hello everyone and welcome to another super high-yield cardiology video for the USMLE STEP exams. Today's topic will be tachyarrhythmias. They are very high-yield, so make sure you know them inside out before you go for any of the 3 STEP exams. Okay, so let me give you a grand overview of tachyarrhythmias and we're going to discuss each one of them separately. So we're going to divide them into 2 major groups: the ventricular tachyarrhythmias, which have wide QRS, more than 120 milliseconds, and we're going to discuss the premature ventricular contractions, the VTach and the VFib. And the other group is the supraventricular tachyarrhythmias, which are characterized by narrow QRS complex. Now, the supraventricular tachyarrhythmias are divided into 2 groups: the atrial tachyarrhythmias, where the electrical impulse is generated, the abnormal electrical impulse is generated somewhere in the atrium. And we're going to discuss the sinus tachy, the premature atrial contractions, AFib, A-flutter, and multifocal atrial tachycardia. The last 3, remember, they are irregular rhythms. They have irregular rhythms, remember that. And the other group is AV nodal tachyarrhythmias. And again, the abnormal electrical impulse here will be generated in the AV node. And we're going to discuss the AVRT and the AVNRT separately. And remember, these 2 have regular rhythm. Very important to know the rhythms and which one has wide QRS and which one has narrow QRS. So let's get started. Before we start, let's quickly remind ourselves about the cardiac conduction system, as we will be using it a lot in this lecture. So here I have drawn the heart, right? This is the right atrium, the left atrium, right ventricle and left ventricle. This is the interventricular septum. And here what I have drawn are several dots. So what do they represent? The first one is the sinoatrial node. The sinoatrial node is the pacemaker of the heart. The impulse that depolarizes the whole heart generates there without any external innervation. So this is the sinoatrial node here. Once the impulse is generated, and by the way, you can go and check out Raj's videos about cardiac action potentials exactly to see how they generate. It's very high yield material for step 1 especially. So once it's generated here, it travels to the AV node, which is located right at the basis of the right atrium, whereas the sinoatrial node is located in the junction between the superior vena cava and the right atrium. So from the AV node, the impulse travels to the bundle of His. So this blue dot here is the bundle of His. And from there, the bundle of His splits into 2, into the right bundle branch and the left bundle branch. They travel here in the interventricular septum. By the way, they're called how? The Tawara branches. And they end up with these little lines here, which are called Purkinje fibers. And they actually depolarize both ventricles. But wait a minute, we just said how we depolarize the ventricles, right? But how are the atria depolarizing? We actually have atrial conduction system, and it consists of internodal tract, and we have 3 of them. So we have the posterior internodal tract, which is called thorough. We have the middle one that connects the sinoatrial node and the AV node again, which is called Wenckebach, and we have the anterior internodal tract, whose name I'm not sure of, and if you know it, please let me know. Now, this is how we depolarize the right atrium, but what about the left atrium? We have another branch there. It's an offshoot from the anterior internodal tract. So it goes like from here and depolarize the left atrium. And it's called Bachmann's nodal tract. And this video will be specifically dedicated on the AV nodal supraventricular tachyarrhythmias, the AVRT and the AVNRT. Alright, so now let's see what is happening in our atrioventricular reentrant or reciprocal tachycardia. Now here I have drawn the heart with the conduction system. So we have the sinoatrial node, we have the AV node, and we have here the His-Purkinje system, conduction system. Now normally the pulse, as we said, travels from the sinoatrial node, depolarizes the left and the right atrium, then goes to the AV node. Through the AV node, the signal travels through the His-Purkinje system to depolarize the ventricles so they can contract. But now imagine there is an accessory pathway that the signal can travel from, right? So the signal can start from the sinoatrial node, but instead of going through the AV node, it can go through another accessory pathway, which can be, for example, located right here, and thus depolarizing the ventricles additionally, apart from the normal signal that travels here through the normal conduction system. And if the signal travels from the atria to the ventricle, then we call this tachycardia orthodromic AVRT. But if the impulse travels from the ventricles through this accessory pathway going to the atrias and then depolarizing them and making them contract, then we have orthodromic, basically backwards atrioventricular reentrant tachycardia. And because the signals now are traveling through different pathways, they will be stimulating the ventricles to contract more, right? That's why it's atrioventricular tachycardia. But why is it reentrant? Well, imagine that this signal traveling from here and then coming backwards to the atrium, imagine it starts making this loop between the AV node and the accessory pathway. So imagine it's going around. It can happen, and that's why we call it reentrant tachycardia. The most commonly seen reentrant tachycardia is the orthodromic AVRT. It's seen in 95% of all reentrant tachycardias. It will start and it will end abruptly in comparison to the sinus tachycardia, which we discussed. Then this sinus tachycardia, if it's caused by fear or anxiety, it's going to start gradually, and there on EKG the peer interval will be normal and you're going to see also P waves. Whereas here the QRS will be less than 120 milliseconds and you're going to have delta wave. Basically, delta wave is a slurring of the initial part of the QRS complex. So if you have the QRS complex like this, it's gonna look something like this. Alright, this will be the delta wave. And you can look up images, of course, online to make sure you can recognize delta wave. So why is the QRS complex less than 120 milliseconds? Well, because the signal traveling through the accessory pathways and not through the AV block cannot be slowed down. Normally, when the signal travels from the sinoatrial node through the AV node, it gets slowed down a little bit. But here, because the signal will travel faster than the normal traveling signal, then the ventricles will depolarize faster. That's why the QRS complex will be shorter and you're going to see this slurring of the initial part of the QRS complex. Apart from that, you're going to have again short PR interval here, and also the heart rate will be 150 to 250 beats per minute or even more. A classic example of the orthodromic AVRT is the Wolff-Parkinson-White syndrome. It presents with all these features and symptomatic tachycardia. Patients with Wolff-Parkinson-White syndrome can be completely asymptomatic. But if they are symptomatic, they're going to present with the symptoms that we just discussed, and also syncope, especially when they have also on top of that atrial fibrillation, or it can even lead to sudden cardiac death. They can also present with or without ventricular tachycardia, so make sure you know this as well. And also, the tachycardia here in Wolff-Parkinson-White syndrome will get worse when you give them calcium channel blockers or digoxin. So this is very important to know so you can recognize it quickly. Now, the best initial treatment of patients with Wolff-Parkinson-White syndrome is one of the following antiarrhythmics: procainamide, ibutylite, flecainide, or amiodarone. Or if the patient is having Wolff-Parkinson-White and he's having atrial fibrillation, then your best initial choices is ibutylite or procainamide. And also eventually you can also ablate these patients. The antidromic atrioventricular reentrant tachycardia will have the same presentation as the orthodromic one. But here what makes it special is that the QRS complex will be wide. So remember that it's going to have wide QRS complex, it's exception to the rule, and this is how you're going to recognize it on EKG. In atrioventricular nodal reentrant tachycardia, we have a reentrant conduction within the AV node itself. So now normally when a signal travels from the sinoatrial node through the AV node and then through the His Purkinje system, it can take two pathways within the AV node itself. It can take the fast pathway or it can take the slow pathway. Now imagine a premature beat comes from the sinoatrial node and goes through the AV node through the slow or fast pathway, and then starts looping between the fast and the slow pathway here within the AV node. So as it loops and it goes round and round and round, it keeps sending signals to the ventricles, right? Additional signals. That's why here the heart rate will be around 200 beats per minute, even more. Now, because we said that there is a slow pathway and a fast pathway within the AV node that this additional premature signal can take, we have two types of AVNRT. In typical AVNRT, the signal will travel from the atria to the ventricles through the slow pathway, and then it's gonna go back up from the ventricles to the atria through the fast pathway. Now on EKG, this will manifest as short PR interval and also retrograde P wave that can actually be buried inside the QRS complex, and you might see no P wave on EKG. And in the atypical AVNRT, the signal will travel from the atrias to the ventricles through the fast pathway, and it's gonna go back up from the ventricles to the atria through the slow pathway. That's why you're gonna see long PR interval. Basically, the atrias will depolarize much slower. Now let's see how do we manage patients with AVRT and AVNRT. If the patient is unstable, then you have to cardiovert them. But if the patient is stable, you can try different things. You can start with the vagal maneuvers, which will decrease the conduction through the AV node. And the first vagal maneuver you can try is the carotid massage. Now the vagus nerve on the left side here has more effect on the AV node. That's why you want to start the massage on the left side first, whereas the right vagal nerve has more effect on the sinoatrial node, just for your information. Now before you start performing the massage, by the way, for 5 seconds, you have to auscultate for something. You have to auscultate for any carotid artery bruits here. Why? Because imagine this is an older patient and they have some sort of aortic plaque here in the carotids. Imagine when you start massaging it, some of this part of this plaque can get dislodged and sent to the brain, right? Thus causing stroke or TIA, transient ischemic attack. So you want to auscultate for any carotid bruits before performing the carotid massage. Very important. Now, if this doesn't help, or if the patient actually has a carotid bruit, you can try with the Valsalva method. If this doesn't help, you can actually immerse the patient's face in ice water. And if none of the vagal maneuvers actually have any effect on the patient and on the heart rate, then you can give them IV adenosine, and you will see the mechanism of action of adenosine in a bit. And if adenosine still doesn't work, then you can try giving the patient non-dihydropyridine calcium channel blockers, beta blockers like metoprolol or esmolol, these are the preferred ones here, or digoxin. And here let's remind ourselves of the super high yield antiarrhythmic drug classes. So on this drawing here, I have shown you on top of the page the cardiac myocytes action potential curve. On the bottom left is the nodal cells action potential curve, and at the bottom right is the heart with the sinoatrial and the AV node. According to the modified Vaughan-Williams classification, we have 4 classes of antiarrhythmic drugs, and by the way, a 5th one, which is I think unofficial still, which we'll discuss in a bit. Now please remember that this classification is oversimplified, alright, for our own purposes, but it doesn't represent properly and entirely all of the electrophysiological events that occur. Now looking at the cardiac myocytes action potential curve, you can see that the class 1 antiarrhythmic drugs decrease the slope of phase 0 by blocking the sodium influx, thus decreasing the depolarization of cardiac myocytes and slowing down the conduction. Now the drugs from class A are subdivided into 3 subclasses. The drugs in class 1A are the disopyramide, procainamide and quinidine. The drugs from class 1B are the lidocaine and mexiletine, and the drugs from class 1C are the flecainide and the propafenone. Class 2 antiarrhythmics are actually the beta blockers like esmolol, metoprolol, atenolol, propranolol. And class 4 antiarrhythmic drugs are the non-dihydropyridine calcium channel blockers, the deutilzem and the verapamil. Class 2 and class 4 antiarrhythmics decrease the repolarization of the nodal cells, thus increasing the PR interval. Class 2, the beta blockers, not only block the sodium-potassium ATPase channel on the cardiac myocytes, thus decreasing contractility, but also directly blocks the catecholamines effect at the beta-1 adrenergic receptors at the nodal cells, predominantly at the AV node, thereby decreasing sympathetic activity on the heart and decreasing automaticity and conduction velocity through the AV node. Class 4 antiarrhythmics, the non-dihydropyridine calcium channel blockers, not only block the calcium L-type channel on the cardiac myocytes, thus shortening phase 2, the plateau of the cardiac myocytes, but also block the same channel at the nodal cells, thus decreasing conduction through the AV node. The class 5 antiarrhythmics that do not fit in the other 4 categories are the digoxin, adenosine and magnesium sulfate. The digoxin stimulates the parasympathetic nervous system by increasing the vagal activity, increasing the acetylcholine production, which leads to stimulation of the M2 receptors on the AV node, which leads to overall decrease in speed of conduction, the so-called negative dromotropic effect. Adenosine mechanism of action is at the sinoatrial node and at the AV node. Now in the sinoatrial node, it blocks the pacemaker sodium funny channel, which decreases the slope of phase 4 of the pacemaker action potential, thereby decreasing the spontaneous firing rate, basically negative chronotropic effect, decreasing the heart rate. Whereas at the AV node, the adenosine inhibits the L-type calcium channels, which ultimately leads to decreasing the conduction velocity through the AV node, the so-called negative dromotropic effect, which can produce AV blocks. And magnesium sulfate is the last drug from class 5, and it is an antiarrhythmic drug that is used only against very specific arrhythmias, like Tourza-de-Pointes. And this concludes our video on nodal supraventricular tachyarrhythmias. This is the last of our tachyarrhythmia video series. Please feel free to check out the other 3 videos that are already on our channel, and also the rest of our videos as well, as I believe they can help you score higher on your USMLE STEP exams. Don't forget to subscribe and share with your friends so we can spread the knowledge. Thank you very much for watching and see you on the next video.